Alors, bonjour à tous.
Hello, welcome everybody. My name is Marie-Ève Letelier. I'm the moderator for this session. This session will be presented in French with interpretation in English. Please choose the language on the bottom part of the screen and you can choose the language of your choice. So we're going to be discussing in this session imagery and lymphedema clinical care. I would like to present Jean Belgrado, professor, MSc, doctorate, and he has a great amount of experience in the treatment of lymphedema. Please consult the program in order to read his full biography. If you have any questions, I invite you to pose your questions and Professor Belgrado will be answering the questions in the chat box that are posed in live time, but unfortunately we won't have time to have a live Q&A session. We will be through our Pathways magazine giving answers to some of these questions. So in the meantime, I invite you to enjoy Professor Belgrado's presentation. Hello, everyone. I would like to thank the organizers of the Canadian Lymphedema Framework Conference for giving me the opportunity to share with you some results concerning the interest of lymphofluoroscopy in the imaging of lymphedema and its treatment within a clinical setting. First of all, a small reminder for those of you who don't know it. Now, this is very simplified, of course, regarding the principle, the basic principle of fluorescence imaging on live persons, and particularly in the clinical setting. The needed material is indocyanine. That's a dye that has been used extensively in the world for almost 40 years now. We use a very, very small amount of this dye, which is sufficient to obtain extremely useful images. It's also necessary, of course, to have the adequate camera, and that will allow us to project infrared light on the person and at the same time to receive this light, which is still in infrared, but in fluorescence. So the principle is quite simple. It's a matter of injecting a very highly diluted amount of the dye. You see that the injected dose is 0.08 milligrams. This injection must be done in as much as possible, as precisely as possible at the intradermal level, because this is where the initial lymphatic network is located. And if we want to see the lymphatic network, then we need to inject it as close as possible to this lymphatic network. So the device, it emits infrared rays that then the indocyanine and the lipoproteins in the dermis that are located at the initial lymphatic system are seen. So this device is equipped with photosensors, including infrared field fluorescence. And as soon as the stimulation starts, then at the time of the injection, we can perfectly see the lymphatic network. We can see the fluorescence here. You see a completely normal image. You see the injection point. And very quickly after the injection, we can see a lymphatic collector. As well, we can also guess the position of the lymphangions at the place where you have this chain image. And these are the different lymphangions that we see appearing in the fluorescence. So as soon as the injection is made, we can have the information concerning the normality or abnormality of this lymphatic network in the person on whom we're performing the examination. It's a dynamic examination, and here's a mirror image of a normal situation and a pathological situation. You can see that on the normal side, everything is passing very quickly. Where on the other side, the abnormal side, you can see that the diffusion of the dye in the network is much slower, and you do not see the lymphatic collectors appearing directly. But on the other hand, you see some small initial lymphatic vessels that are dilated, and you can also see the collectors appear here. For example, you'll notice that this collector does not have a direct direction. You can see that this collector has like a twisted shape and does not go in the direction of the large sense of the limb, but to the side, because there is what we call lymphangiectacy. So from the beginning of the examination, we already have information about the normality or abnormality of the initial lymphatic network. Now, this examination is very useful in situations where the lymphedema is really inconspicuous or where there's a significant doubt about the existence of a problem in the lymphatic network. And now, with the lymphofluoroscopy, this type of question perhaps can be answered quite quickly. And as I have just told you, as soon as the injection is made, if there is a defect in the lymphatic network and at the injection site, well, it can be immediately seen, as I have just illustrated. So where should we inject? Now, contrary to the injection that is done with the lymphoscintigraphy when the radioisotopes are used, in this type of examination, the injection is done in the interdigital space. Now, these injections are painful and can sometimes lead to an injection of the product into the veins, the very, very small interdigital veins, with consequences on the interpretation of the so-called imaging, but that the nuclear medicine physicians, of course, know. In lymphofluoroscopy, it is not necessary to inject in these places. We're going to inject on the dorsum of the hand in two places, this part here in the thumb area and this part here in the fifth finger area. So these two places are sufficient and strategic areas to be able to illustrate, to be able to see the lymphatic currents that you see here. These are the lymphatic vessels. I've highlighted in this dissection here, and you can see the lymphatic vessels on the ulnar side as well as the radial side. By injecting in these two areas, we will perfectly highlight all the collectors that start from the wrist and go up towards the forearm and then to the arm. It's also important to inject at this point and not in the interdigital spaces in order to limit the push of the dyes towards the palm of the hand. Now, why is this important? Because it's really interesting and important within the framework of the lymphofluoroscopy examination to detect where there's a lymphatic sufficiency of the upper arm. For example, in the context of a secondary lymphedema after breast cancer or after secondary or in the secondary lymphedema after adenectomy within the melanomas or in the thorax or the upper limb if there's a lymphatic sufficiency on the forearm. This lymphatic insufficiency is important. Now, part of the fluids in lymph will reverse its drainage path. These fluids will go down into the digital spaces. They're going to pass through the side of the hand to reach the palm of the hand. And in this case, we're going to see a reflux in the palm of the hand, whereas the injection was made in the back or the dorsum of the hand. So I'm showing you here an application of a clinical situation with a patient who had a secondary lymphedema after breast cancer surgery. She has a moderate edema that is perfectly compensated. And notably, it's compensated by drainage via the deep pathways that start from the palm of the hand. This is the injection on the back of the hand. Well, both injections, you can see that there's a reflux in the finger here in the index of the finger and a reflux in the palm of the hand. And this lymph is going to join the deep pathways to join the lymph nodes that pass through the axilla and then join the retroclavicular lymph nodes. Now, this information is necessary for the doctor and for the therapist because for the doctor, in order to have information that there is reflux in the hand, and then there can be the prescription of the elastic sleeve, and this could possibly concern the hand. And so therefore, the physician may advise in these cases to cover the hand as well with the elastic sleeve. For therapists, knowing that there's a reflux in the hand and that this reflux is useful for drainage, the physiotherapists, kinesiotherapists that are going to place the multi-component bandage will take care of the hand, make sure it's not too compressed by the bandage so as to let these fluids naturally reach the palm of the hand in as much as possible to be able to penetrate the deep lymphatic network. Now, in terms of the manual lymphatic drainage, this will allow the therapist to push the fluids from the wrist of the distal forearm area, not to the arm, which is customary, but rather to reverse and push the fluids to the back of the hand and then bring those fluids back through massage methods, drainage methods to help the palm of the hand, and then to try and help the penetration of those fluids into the deep lymphatic pathways. Now, when we inject the dye, it's necessary to apply a manual lymphatic drainage of the fill and flush in order to fill the lymphatic networks and to highlight a maximum of collectors. I'll show you here in the mirror image of 3 situations where I have the same subject, and here is the injection done. And we do nothing else but the injection, and throughout the examination, or in 5 minutes time, we can only observe the 3 collectors, and here we have put fluorescent markings, and the distance is 5 centimeters. So here on the other hand, there's a person who's doing exercises with a ball in the hand, and this allows to increase a little bit of lymph flow in the lymphatic collector. And here we have on the same person has in practice the manual drainage fill and flush from the injection point. And we can see that the images are much richer. And if we go to the end of the last 5 minutes of this examination, I'm just going to skip until that point. You can see that on the resting side, we have on the resting side, we only see 3 collectors. You see 4 on the manual lymphatic drainage, and you can see 6 on the flush and fill side. So if you want to get productive images for interpretation so that the doctors can interpret the examination in the best way possible, it's not enough to just have the pressure associated with the injection, but you have to take between some 5 and 10 minutes while performing the manual lymphatic drainage from the full injection site and fill the lymphatic network. Now, these are fairly simple maneuvers, but it's worth taking the time to perform these. So once the lymph is in the lymphatic vessels from the injection point, and we have really filled the lymphatic collectors, we can make this lymph go up towards the root of the limb, either towards the shoulder or towards the the particular inguinal area. And here's a video where you can see the hand flush when it pushes the lymph into the lymphatic collectors. And we bring this lymph up to the root of the limb in order to see what happens at the root of the limb. And afterwards, I'm going to show you examples of clinical situations so that to see that when we fill the vessels properly, that allows us to have useful information to help the patient who is affected by the lymphedema. Now, because the collectors are not functional in an adenectomy or other situations where the problem with the collector, in which it's no longer able to carry the lymph, you know that this lymph can go up through the pre-collectors, then the initial lymph, and this lymph will, under the effect of pressure, dilate the initial lymphs that normally are not visual in a normal situation. Now, as these vessels dilate, the indocyanine, which is a molecular image that is not huge, can enter into the network, and we will perfectly distinguish this network. And in this lymphatic network with adapted manual lymphatic drainage techniques, there is a way to make the lymph progress in this network. And of course, that has a lot higher hydraulic resistance than the collectors. So if you see the hand again, in the distal to proximal, we're in the forearm level in a person who has secondary lymphedema after breast cancer. There is a way to advance the lymph in their vessels and feed the lymphatic network to the root of the same lymph and to observe the state of the patient's lymphatic network. What we can also see here are some small fluorescent dots on the skin. Now, what are these dots? Well, they're simply the dermal papillae that are invaded by the lymph. The pressure in the dermal papillae therefore increases here. And the diameter of the dermal papillae makes the dermal papillae dilate. And as the dermal papillae dilate and the initial lymphatic vessels start from these to the dermal papillae, but they do not damage to empty themselves. The pressure increases, but we can see through the capillaroscope this kind of structure, and these structures correspond exactly to these little dots that you see here. You see it simply through the capillaroscope, the indocyanine that is slightly green, and you can see that these dots correspond exactly to these dermal papillae. So the interpretation of images is relatively simple. The normal situation is this. These are the superficial lymphatic collecting vessels that are on the forearm, and then you can guess the spaces here that are the spaces between the lymphagions in each location. Here you have a constriction. This is a place where there's like a vacuum. So this is the epidermis, as I just explained to you. Here, this is the initial lymphatic network. Now it's under pressure. And it's a pathological image because if it is under pressure, it is because the collectors, the local ones, are just not functioning. So the lymph looks for another way, and we call that dermal rerouting. However, if the pressure is really high, then what happens? The indocyanine with the proteins that it has brought come out of the initial lymphatic network, and it is this fluorescence that goes into the extracellular matrix. And in this case, we can see an image of cotton that is in the front of the camera, and therefore it's at the level of the skin, and we call this a dermal backflow. Now, the more the pressure is important, the more it'll slide towards images that look like these images rather than these ones. So among the applications, we can understand how this lymphatic network works, which, like if I show you a very simple video that cuts through some of these ideas or some assertions that have been made somewhat quickly, you know that the pressure that can be present under the elastic sleeve, this is a class 2 elastic sleeve, it's a collector. You can see the image is relatively diffuse. Now, this is quite normal because we've covered the person's limb with their elastic sleeve, and you can see that under an elastic sleeve, well, here's the video. Now the hand is at the bottom of the image, the shoulder towards the top of the image, the elastic sleeve is placed. We can see the fluorescence through the fabric, and you can see the presence of the elastic sleeve. It doesn't slow down. The flow does not slow down the lymph flow. It doesn't speed up, but it doesn't slow down either. The imaging is also interesting in relation to these elastic restraints or sleeves to resonate. Well, like to know how far the restraint should go up the arm of a patient. Like here we have a patient who has secondary lymphedema after breast cancer, and you see that she compensates for her lymphatic drainage by the initial lymphatic network, and the initial lymphatic network in this territory is not covered and it doesn't benefit from pressure. So you have to propose to this patient an elastic sleeve that goes up a little bit. And there you have information which allows you to justify this proposition. Or this proposal. So the other information she gives us at this elastic sleeve is much too small. It created a very important pressure at the point of the rubber band because of the very small surface of the rubber band. It creates like a type of tourniquet. And I say a tourniquet, it's not a blood tourniquet, obviously, but it's a tourniquet that's going to crush the initial lymphatics. So these are they're these are not collectors in which there's a significant pressure. These small lymphatic are crushed when we have a sleeve when the elastic is just too small. So now all manufacturers know that these elastic sleeves have understood this situation. They offer an extremely wide elastics in order to avoid this. Now, the lymphofluoroscopy also allows us to study what happens under the compression therapy cuffs, whether for the upper, the lower IMS. So we have both in patients and in subjects who don't have edema, healthy patients. You can see the fluorescent landmarks. You can see them here. We're going to find them in the video. So the camera observes under a transparent cuff the lymphatic collectors during the inflation of the cuff. The cuffs are inflated at different pressures, and we can see and study if the compression therapy prevents the lymph transfer, if it improves, if it slows down, and so on. So here I can give you the information that the pressure the intermittent compressor is at 30, 60, and 90 millimeters of mercury, as we did, and that does not prevent the lymph from advancing in the collectors. On the other hand, it doesn't help the fluid transfer from the extracellular matrix toward the lymphatic collectors. Now, we already know from other studies that have done with the lymphoscintigraphy, and here we have confirmation of this with the lymphofluoroscopy. So the message is that if there is lymph in the lymphatic collector, it will be pushed by the compression of the cuff, but the lymph does not accelerate the lymph flow in the lymphatic vessels. This doesn't prevent compression therapy from mobilizing the fluids within the extracellular matrix and pushing the fluids up through the extracellular matrix toward the root of the limb. So now here's another application. Now here we're talking about a woman who had breast cancer, and she underwent a lumpectomy. This woman developed edema of the upper limb, a slight edema. And on the other hand, she's complaining, and she comes to the multidisciplinary consultation because she said that there's this tension discomfort in the breast area. And we want to see, with the help of the lymphofluoroscopy, if we can understand some elements in order to explain why this woman feels this pressure in the breast area. So here's the examination. The injection is made again at the hand. You can see this woman has no reflow in the palm of her hand. And when we go up the dorsal area of the forearm, we can notice that there's lymphatic collectors that are still quite functional. So we can drain this very easily, circulate the lymph. However, there are areas where you can see this dermal rerouting. So we know, obviously, that these areas shows that there is a lymphatic insufficiency. And when we go to the forearm, this time at the level of the anterior side, we see the dermal rerouting network, which is very important. You don't see any initial collectors, but you can see there is a way to push the lymph and to evacuate the lymph with disto-proximal massages. And it's quite simple to do that. So we're at the level of the arm. I'm going to stop the video here. We're at the axilla, and you will notice the initial lymphatic vessels are dilated and bring the lymph not towards the axilla or the armpit area, nor the lymph nodes of the axilla, since this woman probably doesn't have any functional ones left. However, the lymph finds its way down the flank through the initial lymphatic network, which is dilated, obviously, since the breast almost has no lymph nodes in the axilla area that can drain it. And there's other lymphos and other areas, other vessels to be able to put this stop. And when we continue the examination, we continue the exploration of the fluorescence, we're going to go back down to the lower lateral part of the breast. You see the initial lymphatic network that is gorged with lymph, and with the hand pressing sufficiently and slowly down, you see that it's all about the slowness. You can see that there is a way to push that fluorescence and therefore push the lymph into the breast. And actually, this woman that's complaining about the tension in the breast, it's most likely due to the lymph, or part of the lymph of the arm and the forearm and the hand that's going to drain through the dermal lymphatic network, the initial lymphatic network in the breast, as well as in the treatment when you note that information. So the patient is already relieved by the information that the tension in the breast is not due to the relapse of the disease, of the oncological disease, but this tension is due to the lymph from the arm of the upper limb draining into the breast, and this allows us to teach the patient in front of the camera to drain herself. And this allows the physiotherapist and therapist to choose the treatment strategy and maybe to intervene with multi-component bandages to reduce the tension in the breast. In any case, a drainage map of the upper arm and breast area of this woman was done thanks to the lymphofluoroscopy. Here we have a young lady, and she's been affected by a primary lymphedema. The origin of this primary lymphedema can be investigated by doing a lymphofluoroscopy. And here we have injected it at the foot level. And what we're doing, we're going to look at these lymphatic collectors that are present anatomically speaking. They're present, but you can see there's a problem here. You see that I'm pushing the lymph back. I'm doing this pushback, and you can see that the lymph comes back simply because this patient has a defect of the lymphatic valves. And we can show this with this examination that shows that this woman does have lymphatic collectors, but her problem is related to the valvular incontinence. I'm going to show you a secondary patient. Now, this is in a different patient here. And this patient also has a defect at the lymphatic level, but it's enteric. Now, I'm showing you the video at the foot level. You can see that here too, she has a valve defect. She has collectors that are present, but these collectors, unfortunately, don't have valves at all there. You can see that the lymph goes back down each time. No matter how much I pull it up, this lymph goes back down. We know, and we can help this patient by also directing the genetic examination towards genetic mutations that are known and that correspond to valve insufficiency. Here we have another clinical situation, and this is a young woman who had cancer of the uterus. The surgeon had to perform debulking. It was a really big surgery because the tumor had affected other tissues. During the surgery, everything went out well. You can see the scar here. The surgeons had to perform a laparotomy a few days later after the surgery. And the patient then developed edema of both lower extremities. So very quickly, the diagnosis of secondary lymphedema was made. When you have secondary lymphedema that sets in so abruptly and so quickly after this type of surgery, always think that it is most likely not a lymphatic insufficiency of the lymphatic vessels of the limb at the distal end, but probably a reflux of the thread related to the lymphatic vessels that were severed during the surgery. So for this, a lymphofluoroscopy was performed with an injection at the foot level. During the examination, it is found that the lymphatic vessels are completely normal, that there is indeed a significant fluid stasis. If with passage against the side, given the patient's situation, given the situation of the surgery, and given how quickly this edema set in, it was very likely that it was Shiel reflux. So the surgeon places a drainage, and indeed you can see that it was a thread that was present and dripping going down into both of the limbs, and this is what is causing this bilateral edema. This treatment was put into place very quickly, so the drain was installed and the multi-component bandages were placed very quickly on both limbs. And in a few days, the patient recovered her limbs, and they were completely normal, and even today. And this is a patient that we're still following up with. She has a little bit of edema here in the inguinal or groin area, but between her post-operative situation, which was and the treatment follow-up was done, and this patient is really happy to have her limbs the way they are now. If we don't do this treatment quickly, if the diagnosis is not made quickly, it's quite a shame, because both the extracellular matrix will expand and on both sides, including the swelling with time, is going to settle in there. So it's really worthwhile to do the lymphofluoroscopy very quickly to see if the lymphatic system is functioning properly, and think about this in a multidisciplinary manner to try and understand the origin of this sudden lymphatic edema. So lymphofluoroscopy, when it's used before cancer surgery, it can detect secondary lymphedema and also detect which patients are at a very high risk of developing the secondary lymphedema after surgery. So we set up a study that we've been carrying on for around 4 years, and we enrolled in this study 92 patients who needed surgery for breast cancer. And then we performed a lymphofluoroscopy. Now, this was done before the surgery, and we measured segmentally the volume of the hand and the different segments of the arm and the forearm. And then we compare those volumes with the images that we recorded. And then we did the same examination post-operatively at 10 days, and then 3 months, after 6 months, 12 months, and then after 24 months. The patients throughout the study that had images that remained normal never developed lymphedema. Patients who at one point in the study showed these typical dermal rerouting images around 3 months, 6 months, depending on the patient. These patients developed secondary lymphedema. So we had to put off the cutoff at 5%. Lymphofluoroscopy, as we practice it in Europe, is still in its infancy. And yet in China, there are already publications as well as technologies that are done along with lymphofluoroscopy as we practice it in Europe. So it couples this with principles, photoacoustic principles, and these techniques allow to visualize the lymphatic network on a superficial, deep, and three-dimensional level in order to highlight as well the initial lymphatic network as well as the lymphatic collectors. So the future is here, and that's going to allow us to better help doctors in order to make their diagnoses and to better understand the physiology of the lymphatic system and better understand the anatomy. When you look at these images, you can see that this lymphatic system is three-dimensional and that the notions of the deep lymphatic system are separated from the superficial lymphatic system. And in fact, they're just images in our mind. And in reality, we have to take into account that it's three-dimensional. This network is interconnected at all levels. Thank you for your kind attention, and I wish you a great rest of the conference. See you soon.